And welcome to Karen again this month. We are very pleased to have her, and also very pleased to meet with Claudette, who works, I think, in close conjunction with Karen. I'm sure Karen will tell us a bit more about her. Thanks very much, and thanks to everybody who joined us. Karen, over to you.
Thank you. A word or two about Claudette. Claudette actually started Retina South Africa before some of us were born. And as a visually impaired person herself, she has been a spearhead in driving its non-government organization and non-profit organization really, really well. Claudette is a scientist and is head of science at Retina, and is a wonderful colleague and ally. And she's actually my boss. So,
Hardly.
But we work very, very closely together in all things. Okay, so I'm going to start screen sharing, and then I will start presentation. And we're going to talk about why don't these meds work for me. Good. Can you all see it?
It's fine, Karen.
Oh, perfect. Okay, so we're going to talk about why don't these meds work for me? Why do they work for someone else and not for me? And the answer is, in fact, it's all in the genes. But let's have a little bit of a closer look at exactly what we mean by this. Reminder, just before I start, that as we mentioned before, both Claudette and I and a couple of people who are here today are from Retina South Africa, where we provide a multiple of services to patients with all kinds of retinal problems. And we only have a voice, for example, in advocacy, if as many people as possible do join us. So please, everybody join us so that we can talk together to get fair and equitable treatment for every single person in this country with a retinal problem, with trying to adapt to low vision. We are a fairly small team, but we are really effective. And also a reminder that we also work very, very closely with the Low Vision Centre of Learning, which is situated in Blackheath. And a quick disclaimer that this program is made possible thanks to an unconditional grant from Bayer South Africa, and that is an unconditional educational grant. It is used for those purposes only. What we're talking about today is pharmacogenomics. Now that sounds like a very, very, very big word. So, but what does it really mean? Let's have a look at what this huge word means, because it is the future that is happening right now. And it is the science of personalizing your medications based on your own individual DNA profile. So we know that if we dose medicines based on the genomic profile, we have far better outcomes, because we know that some things work for some people, some work for others, and some don't work at all. So at the moment, this is a bit of a hit and miss affair for every single medication that we have. And although this sounds a little bit new, pharmacogenomics, this science of the way medicine is going today has been around for a good 10 years or so. And there are lots of journals, but not only journals, there are also popular publications that have been highlighting the future or the now of how medicine is going. Time magazine says that the drugs of the future, but a lot of them are happening now. And within the next few years, in fact, a prescription will look more like this, that you'll have the patient's name and address. That's the way it normally is, but it will also include your DNA profile, so that every single medication that is prescribed is very specifically done just for you. So if we look at the world today, why have we had to take this stance? Because if you look at it, yes, we all look very similar. We all have two eyes, a nose, a mouth, two arms, hands, etc., etc. But are we really the same? Are these two people really the same as this family, although both are on the same continent? So if we look at the two, they share a staggering 99.97% of their DNA. The people in the top picture and the people in the bottom picture. 99.97% of the DNA is absolutely identical, which means that there's only a 0.03% difference. But that 0.03% determines everything. Your hair color, the texture, the waviness, your skin color, the texture, your eye color, your size, height, your shape, and so much more. Every single thing that makes you, you, and completely unique. So, why then is this so very important to us? Because we all have the similarity, but these tiny differences that have such a massive impact on everything. We know that some people can eat and remain trim. Others eat one donut and then gain a kilo within an hour or two. Some people can have one tot and are completely drunk, and others can have a bottle and are absolutely fine. Some never exercise, remain fit. I'm sure you get the idea of where we're going. And of course, some people can sit in the sun, develop a tan, and others get severe burns with blistering after just a few minutes. And some people can have espresso at bedtime, others can't. And of course, it is not surprising then that medicines that work for some people may not work for you. So if we look at the way medications work, at the moment, this is the way the hit and miss approach goes. We know that we can give medicines to some people, as I've circled there on the top right, and they have a benefit and they have no toxicity, no problems with it, no side effects, and that medication works fine for them. Some people have no benefit and they get the toxicity. So they have a reaction and the medication does zilch for them. Some people have a benefit, but then they have to sit with the toxicity. So it works well for them, but they do get the side effects. And some people have no toxicity, but no benefits. So as you can see, any prescription is going to place you into one of these four categories. Are you going to have a benefit with no toxicity, or a benefit and you have a massive side effect? So the only way that we know at the moment is by trial and error. And as you know, even simple things like penicillin and things like that, we only know after you've had it. And the reason for this, once again, is because it is all contained in our genes. What is in our genes will determine exactly how we react to every single medication that we have. And then just as the way our bodies handle coffee, alcohol, food, everything else, we all metabolize those medications completely, individually, differently, and it is up to our makeup to determine how we are going to react. And even things like aspirin, paracetamol, antibiotics, cholesterol-lowering agents, vitamins, diabetes medications, all of these things that are often prescribed across the board work for some people, but not for others. And that is why there is such a variety. Every single one of these, even a lowly aspirin, will affect you one way and your neighbor a different way. The person in the supermarket queue next to you a different way again. And there's no exception with every single medication that you can think of. Our individual responses are just so completely different from each other. Now, this is quite interesting because in the United States and in the UK, people are now able to shop in certain areas based on their DNA, because they have found that there are certain that work well for some people and are a disaster for others. Some people can metabolize some things, some people can't. So if you go, for example, to some of the Waitrose or John Lewis stores, you go in, and the first thing that they do is a quick swab. It's a cheek swab. It takes a couple of seconds, moments, and you get the test within a few minutes. And that generates a personalized DNA report. Now, your DNA is not going to change when you go shopping next week and the week after. Your DNA is your DNA, so you only ever do this once. And once you have that profile, you are set to go. Then you can either use the little bracelet that is shown in the picture here that you put on your arm, or there is a smartphone app that you can use. And as you shop, you scan the food product and drink product, and that will assess that product's suitability based on your individual DNA. This is not happening tomorrow. It's not happening next year. It's been happening for quite a few months already. It is established and it is going really well. And the DNA band or the app will flash green if there's a good match and if that is something that you should be eating, red if it's not. And if it comes up as red, it will give you a good alternative for you in green. So you don't have to shop for stuff that your body is not going to use well, that your body is not going to metabolize well, that your body cannot use. And you're able to select stuff specifically geared for your individual constitution. And these grocery stores are right across the UK and USA. And as we said, the test is at the store and you shop accordingly. So if this is already available for things like food, it makes sense that the medical profession has to start looking at prescribing medication based on our individual DNA profile. And there are a few that already do so, but not enough. And the future is not only approaching, it is right here. And pharmacogenomics is an absolutely critical area for improving drug therapy and prescriptions in the future. And we're going to see why, because there's quite a lot of reasoning behind this. Pharmacogenomics challenges the view held amongst some fairly old-fashioned doctors and pharmacists that drugs are pretty much the same for everyone. They are not. And we know that more than 50 million DNA variations have already been identified, and Claudette knows a lot about this because that is her area of research, and thousands are associated with very specific diseases in the eye as well, and thousands more have been associated with specific drugs that do and don't work. And hundreds and increasing numbers of drugs with labels will start to include a full pharmacogenomic information on the label. And this will be based on the associations found between the genes and the sensitivity of that product or that person to a certain drug. So the studies already show
medications are ineffective
in 40% plus of patients with asthma, depression, and diabetes. So we are giving people medication for asthma, depression, and diabetes, of which 40% is useless. It is not working. It is ineffective for that person. And it has nothing to do with the quality of the drug. It has nothing to do with the physician's treatment. The basis is that we are simply all unique and we don't all react in the same way to everything. So, for example, if you just look at something like diabetes and you look at just a few of the genes that are involved, how do you target one of this multitude, this confusing mess of what is going on in a person's life, and try and treat them with a drug for just that, like people gamma or one of these things. You can't do it. You need to know a lot more about the person so that you know what is going on in that person's life. And because we're talking about eyes, we're going to talk about anti-VEGF, which is the injection into the eye to protect your eye when you start getting those little bleeds into the eye that could destroy your vision. It has been found that there are certain genes that require that people have to have extra injections, because just one injection or the amount of injection being given is not enough. And their response is curtailed if they have this gene. And if they have other genes, they respond very, very well. So now how do we know? And remember that these ranibizumab is really expensive. It retails at about 7,500 Rand per injection. So if we look, this single gene with a poor outcome needs to be identified so that we can find, because we already know which gene it is, so that we can find exactly which people we should be giving this product to and which people should be getting something else. If we look at people's reaction to anti-VEGF therapy, and this is very much in the news, Claudette and I were talking about this morning, there is a problem with one of the anti-VEGFs busy coming onto the market because some people are developing side effects to it. So how do we determine who those people are? Who's going to be the person to get the side effect? How are we going to know? Are we going to give them the injection and just say, oh, well, we hope you're not going to have a problem? The problem at the moment is that if we don't know how to predict how the person is going to react to that medication, we're taking a chance in giving it. We need to know their genetic makeup, because the genes will determine absolutely everything about how every single person reacts to every product. I'm just going to say a word or two, because people sometimes say to me, my genes changed because I used to react to something well and then it stopped working for me. That's a term called tachyphylaxis, and this is simply a medical term. It's a very smart sounding term describing a decrease in a person's response to a drug after you've been taking it. That doesn't mean your genes have changed. It just means that your body has somehow adapted to that medication. And it can occur after just one dose, or after you've taken it for years, it suddenly stops working for you. And if it does occur, the doctor normally stops the medication, switches to a different drug. And if it's one of the products in the eye, the best choice is, because there are 3 very well-known products on the market at the moment, if one doesn't work for you, you switch to one of the others. Now, in other words, we do need to start looking at genetic testing before we prescribe medications. And if we look at the economics, we find that even there, data suggests that giving medication based on pharmacogenomic outcomes eliminates the costs of morbidity, ineffectiveness, reactions, hospitalizations, even death. So morbidity, mortality, ineffectiveness, reactions, wasting money, chucking money down the drain. In a 3,500, more than 3,600 study, they found that hospitalization rates for heart patients were reduced by just over 30% if the genetic info was available for doctors prescribing just one medication, and that was warfarin. And there are so many people taking warfarin, and I wonder how many are taking it based on their own DNA reaction to this product. But in the study, they found that if they knew the DNA profile, they were able to reduce hospitalizations by 30%. That's huge. Because at the moment, as I mentioned earlier, and this slide just highlights it again, what we do with our standard approach at the moment is we give a medication and we just hope that it is going to be effective. We know it's going to be effective in some of the people, usually approximately 20% of the target population will react well to any given product. That means that 80% of what we are giving people is going to waste. The tailored approach would be to look at the DNA and then take the choices. Is treatment A, B, C, or D the appropriate one for this specific patient, so that we don't waste 80% of the expensive medications, plus, as we've said before, the side effects, the problems, the hospitalizations, the hassles that go with it. Now, we know that even today, there are more than 100,000 genetic tests available, with more than 10 introduced every single day. And they're available here in Johannesburg. You can just walk in and get a genetic test to determine. And when you've had that done, this is what your medication list will look like. They'll take a medication on the left-hand side, or the disease state on the medication, and then your risk status will be written on the right-hand side, that there's no risk to taking this product. Also, if there's any benefit to taking it or not, if you could have an adverse reaction or not, if the effectiveness will protect you, etc., 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 or if you need a slightly higher or lower dose. So medication, even today, is beginning to look like this. And I know that Claudette and I work with a colleague, and he's had this done, and he said that his profile already for his medication looks exactly like this. The treatment of macular degeneration, because that is what we need to talk about, these days we know we need to intervene early, and we know also that we have those injections to try and stop the disasters that are associated with wet macular degeneration. And we know that lifestyle is important. And just to remind you once again, because we did mention it just now, that there are 3 available products on the market at the moment, plus 1 that is off-label. So in the future, a pharmacogenomic test could help to avoid adverse reactions and ineffectiveness of medications instead of this hit and miss idea that we have at the moment. It will help physicians to work out your most important treatment, your most important drug for each and every different complaint that you have. And it will be an extra element to bring medicine from a reactive discipline, which is what we do now. We wait for you to get sick and then we give you something. With that DNA knowledge, we'll be able to do that in advance. And besides improving how drugs are used, it will enable us to develop better and better and better drugs that are more highly effective and don't cause the serious side effects, because we'll be able to pinpoint exactly where those side effects are coming from and do something about it. And if we look at something like sub-retinal genetic therapy, this is already just about here. It increases the action of anti-VEGF, and all this is a tiny injection under the retina, and then you give the anti-VEGF, which, as I mentioned earlier, is quite an expensive product, and you give 2 doses, and then after that, only VEGF ever again in your life, if needed. And they found that in the trials, after a year to 18 months, no extra medication was needed. The injection, as I said, is tiny. It's only 100 microliters of this product. And not only that, they found that patients who were getting this gained 9 to 12 letters on the eye chart after 12 months. In other words, their vision improved. Not only did it stop the damage from getting worse and the degeneration from continuing, it actually improved the vision as well. So the future, we don't have to wait for it. It's not distant. It is now, because newer, smarter, more specific drugs designed for you are regularly becoming available with new delivery systems. And to note, 20th century medication, 20th century medicine in total is history. It's gone. It's yesterday. And just remember, if we could get everybody to register with Retina South Africa, we would have a really, really strong voice together. Thank you. Thank you, Claudette. Thank you, Maxine.
Thank you so much, Karen. You know, I've worked with Karen for a few years now, and every time she talks, I still learn something. She is such a wealth of knowledge. And the big thing is that she keeps up to date with all the research. So I haven't seen anybody put up their hand. And if anybody would like to ask a question, I don't see anything on the chat. So you can just unmute yourself and ask Karen a question.
Maybe everyone understood everything I said. And I've
Thank
given
you
them
very much, Karen. Thanks, everyone. We're having a power outage, so I'm lovely to leave you. Thanks, Amal.
Thank you.
Karen, hello there, it's Jenny here. Sorry, I'm one of these who goes back to your previous talk, which again I was dwelling on, and thank you for today's. But that question about daily oranges, and you said we needed to obviously have the full orange, not just the juice. Does this also, what is so specific about the orange, say, compared to a grapefruit or or something?
Okay, this has been the subject of a lot of research, but mostly out of Australia. And they found that an orange contains a product called hesperidin that is not found in any of the other citrus fruit. It is specific to oranges, and it is only found in the little cell of the orange. So that's why you have to have the orange with the pulp. You can't just have strained orange juice. It has to be the whole orange and with the cells. And even if it's oranges are out of season and you go and get one of the orange juices, make sure that it's the one that says with cells or with pulp. It usually says one or the other.
Yes, thank you. What was the name of the little thing in the cells?
Hesperidin. Hesperidin, I think. Hesperidin.
Okay, thank you so much. No, that's because then I'll have a mix. Thank you.
Oh, we have got something in the chat. I've just picked it up. Gail, thank you so much, Karen. I don't have a retina problem, but I do find your talks so interesting.
Thank you.
Thank you very much. And then from, I can't see who's that from, but it's very informative. Thank you very much, Karen.
Thank you.
People can always email us. Our email address is headoffice@retinasa.org.za, and we will obviously try and answer your questions. But I just want to comment on what Karen has said about medications being so unique to us. And a lot of people are still getting medication from their neighbor or a family member. And really, that's not a good idea because, you know, their doctors obviously examined them and seen their reaction. And your neighbor or your family member, no matter how well-meaning, cannot give you their medication. So please never take any medication, particularly statins or hypertensive drugs that have not been prescribed specifically for you. And just to talk a little bit about protection, we know that if you do exercise and you do have a good diet, you can prevent a lot of these age-related conditions. And it's not only vision, but certainly hypertension and many others from happening. And people say, well, I can't exercise because I can't walk outside. I live in a dangerous place, or I'm not steady on my feet. But everybody can exercise. You need 50 centimeters square to exercise, or even just seated in a chair. You really can just walk on the spot, swing your arms up and down, do some circling with your arms, just do some cycling with your feet. You can exercise, and you need to exercise even if it's just for a few minutes a day. And talking about diet, we all know what we can and can't eat. We all know that we should not eat too much red meat, and that we need to be very careful about simple carbohydrates, sugar particularly, but the others are also just as bad, and that we should eat a very colourful diet. And I know Corin did go through this with you in one of the previous talks, but I really want to emphasize just how important it is. If you pick up something on a supermarket shelf and you can't understand the label of what the ingredients are, then put it back, because it means it's full of artificial colorants, flavorants, and additives. So eat as healthily as you can.
Well, I'm hoping that those bans, those shopping bans, come to South Africa soon.
Yeah. Well,
because it's not expensive either, I think.
Sorry. Yes, I see that it was Waitrose and John Lewis,
Yes.
UK stores. How do you go about possibly motivating our stores like Woolworths and contacting them directly and saying, hey guys, what are you doing about this?
You know, a lot of these things depends on having a good contact and knowing someone in management to be made aware of what is available, and to point out that it's quite a draw card, because I certainly know of some people living in the UK who didn't get the ban, but they do have the app on their phone, and they will go and look for a Waitrose so that they can get food that is appropriate for themselves specifically. And the original test, it's a once-off. You only ever do it once. And then at least you know that what you're buying for yourself. And remember, genetic traits seem to run in families. So you might not need to test your entire family, although obviously if you can, that's even better. But you'll probably find a trend in a family that something that suits mom and dad will be fine for the kids as well.
Jenny, don't be discouraged. You know, just go onto the Woolworths website or stores like that you want to target, and go and see who contact us, and just keep emailing them. You know, eventually they will get tired and somebody will answer you, and perhaps you might just plant a seed. You know, we all can do something. We mustn't think that we are too small, or our voices too little, too soft to be heard. We can all be activists and advocates.
Thank you. And you mentioned that this testing is available in Johannesburg. Where would that possibly be?
There are quite a few of these labs. I know that there's one in, what's that centre, Claudette, can you remember? It's the name of another shop. But there are quite a few. I just happen to know about that one because I know a few people who've been to that specific one.
Not the Strap Centre.
Yes, Strap Centre, thank you. I know that there's one, but there are a few others. There's one in Parktown North. And as I say, it's only because anecdotally people have told me they've been there.
But we'll try and find out, Jenny, and let you know.
No, thank you. I'm not in any problems, but it's just of interest because I know folk who could, really benefit from this.
Absolutely. And, people who are really highly allergenic, I'm allergic to everything, and I've always got hay fever, and those people. They don't, they're obviously not happy within their bodies. I think those kind of people would be obviously people to actually target.
Thank you, everybody. Lovely to see you.
Thank you very much.
We hand over to Maxine to close.
Corin, that was really, really informative. And I think we all learned something today. I think many of us are taking lots and lots of meds that maybe we really don't need. And I think that what you have told us today is certainly something we need to think about and get word out as soon as possible to try and get people aware of it, to know about it. Even the doctors, you need to mention it to your house doctor or your specialist and say, look, I'm going to have this DNA test done, and please, can you check on my meds to see that I'm really on the best thing for me? So I really think today was very informative. Lovely to meet you, Claudette, and Karen. Thanks a million for everything that you've done for us. Much appreciated.
Thank you.
Thank you.